Hello, this is Forrest Blocker. Today we're going to be talking about gene therapy, leading up to a discussion about cancer gene therapy. But first we're going to be talking about blood and immune deficiency diseases as covered in ASH last week. Let's begin. Gene therapy has a goal of correcting mutant genes that result in disease. Gene therapy can, in theory, correct these genetic errors in a variety of ways. You can replace the incorrect gene, you could add the gene, you could remove the incorrect gene, and you could introduce temporary genes into appropriate cells without incorporating them permanently into the host or patient chromosome. So let's think about that a little bit to begin with. Temporarily adding a gene is easier and less of a concern than replacing or removing an incorrect gene. So we have to understand that the way that genes work, according to the central dogma of molecular biology, DNA holds information which then can be transcribed into messenger RNA when it's needed for producing machinery that can do things in the cell. And those things are done by the product of translation, where the messenger RNA, originally transcribed from the DNA, becomes translated into little protein machines. So in some cases, some diseases are caused by multiple genes that either don't create or cannot create the correct protein, create too much of the protein, or create the wrong protein. So those are some common things that can happen, not the only things that can happen, but some of the common things that can happen when something goes wrong with a gene. That can be something that you're born with, or it could be something that you acquire due to genetic damage that occurs to all of us all the time by just the effect of being alive. So as you might imagine, if you are missing a protein, whether you're missing it because you weren't born with it or because you've lost that gene, adding a gene is easier from a technical point of view as well as from a safety point of view than removing or replacing a gene. So that's something sort of to keep in mind as we go along in this discussion. Okay, so gene therapy has been promising for a wide range of human diseases, including some severe immunodeficiencies, some storage disorders, hereditary blindness, hemophilia, hypercholesterolemia, cystic fibrosis, Parkinson's disease, Lou Gehrig's disease, and cardiovascular disease, and most recently also cancer. So far, there have been more than 2,000 gene therapy clinical trials worldwide, with a few gene therapy products having been approved, not approved in the United States or in Europe, however. Most of those diseases are monogenetic, meaning that there's one gene that has gone wrong, and so there is one target to the genetic therapy. So the first set of diseases that I want to talk about that have had some success with gene therapy is blood diseases, and included in this is beta thalassemia, which is a genetic disorder of the hemoglobin molecule. It was the first gene therapy attempt, the first attempt to treat a disease with gene therapy. It was attempted in 1980. In that case, the researcher, whose name was Klein, didn't publish his results. And of course, it's always a red flag when results of an experiment, let alone a trial, are not published. Because, of course, in science, it's very important that people who have expertise in your field can review the data. In fact, they should be able to review the data to such an extent that they should be able to repeat your experiment. So there is legitimate skepticism about whether or not he was even able to deliver the gene which he was trying to deliver into his patient. In 2007, quite a bit later, an 18-year-old French patient received gene therapy for beta thalassemia. Blood cells were taken from his bone marrow and were treated with a lentivirus to transfer a working copy of the beta globin genes into the cell, which were then returned to his body, where they produced the correct beta globin, eliminating his need for blood transfusions to the present day. So that was 8 years ago. And understand that in this particular disease, it is monogenetic, meaning that there's only one gene that goes wrong, and it is a loss of function mutation, meaning that you don't produce a working copy of a machine, the beta globin protein, that you need for your cells to function correctly. So this would be a case of a disease where you would expect it to be most easy to treat because you are adding function. In this case, they've taken stem cells, they've treated those stem cells with a virus called a lentivirus, which was engineered to include a working copy of the DNA that codes for the mRNA that will then code for that protein. So as long as the lentivirus gets into the stem cell and the stem cells take those genes, now those cells can produce the correct protein in perpetuity. That treatment was called lentiglobin BB305, and it is currently undergoing a clinical trial with 10 patients, which is expected to be completed this year. So one would expect that the clinical trial needs to see what kind of adverse events the patients might experience. And one might expect that for a trial like this, you want to be very careful to look for adverse events that might take a long time to develop. And in fact, we'll look at some cases of some similar treatments that resulted in some very serious adverse events. And we'll talk about why those adverse events took place. The other thing, of course, that you want to check is you want to be sure that that the treatment actually delivers the gene, and that the patients can, for some time or maybe for a long time, produce their own working copy of beta globin, thereby curing them of the disease. So the next disease is a related disease. It's a disease called hemophilia. And of course, in hemophilia, one experiences bleeding due to the loss of a clotting factor. And there are different clotting factors that one can lose that can cause hemophilia. In this case, we're talking about losing clotting factor 9. So the clotting factor is a molecule that is produced as a result of a gene, and when that gene is mutated, you lose the ability to make that molecule, and so again, this is a loss of function disease. where the treatment is to artificially provide that function again. In 2011, a trial was started wherein the researcher used adeno-associated viral vector. So after treatment, most of the patients in this 2011 trial made at least some clotting factor 9, meaning that the gene was correctly delivered and able to go through the process of transcription and translation. And as a result of that, they had fewer bleeding incidents. 3 years later, in 2014, all of the patients were still producing the clotting factor. A company called Sangamo has a hemophilia B program called SB-Fix that has been cleared by the FDA to initiate a phase 1/2 trial in 2016. So the data was presented last week at ASH. The data presented demonstrated that a single intravenous administration of this adeno-associated viral vector carrying a donor HFIX sequence resulted in clinically relevant levels of circulating HFIX with only one single weak off-target site. To be talking about a single weak off-target site, that's a little bit of a concern. One of the problems that gene therapy has been shown to have in general, regardless of the delivery technology to put the gene in the patient, is that these genes can sometimes go into the wrong place in the wrong chromosome, or the wrong place in the right chromosome. And that is a very, very big concern, because when a gene goes into the wrong place, it can set off a cascade of events that has been shown to contribute to things like leukemia. The next blood disease is called sickle cell anemia. And as you probably know, sickle cell anemia is a disease that causes beta globin to be misshapen. The hemoglobins will just form these long, temporarily stuck together oligomers of the protein kind of stuck to itself in a long chain. And that causes the red blood cell to become sickle-shaped. A zinc finger nuclease is being tested for the correction of this beta globin gene in sickle cell. So again, this is a disease caused by a loss of function, the loss of being able to make the right hemoglobin, which deters your ability to carry oxygen and changes the shape of your red blood cells. We want to introduce the correct gene, and so the technology being tested now, uses something called the zinc finger nuclease. So clinical trials of this gene therapy for sickle cell were started last year. Bluebird Bio has presented data on their drug lentiglobin BB305 at ASH last week. Patients in the company's small HGB206 study showed gradual increases in normal, non-sickled hemoglobin, but those effects were much lower than levels seen in previous subjects. So this hints at the idea that there is not so much a concern of not putting the gene in the right place, but not putting enough of the gene into the patient to affect the production of enough of the properly folded hemoglobin. So there could be a variety of reasons for that. Maybe there's something fundamentally wrong with the the engineering of the drug, or maybe they're not delivering enough of the drug, or maybe the patient population wasn't carefully selected. There are a variety of reasons. So a lack of efficacy is something that one would have to expect will be studied for some time. Whereas if there were serious adverse events, that would put the kibosh on the trial much sooner. Okay, the next category of diseases that I want to talk about are immune deficiency diseases. So the first immune deficiency disease that I want to talk about is something called SCID, also known as the bubble boy disease. So, as you can imagine, it's a very rare disease. The initials SCID stand for severe combined immunodeficiency, and it's defined by a defect in B and T cells. There are two genetic variants of the disease. One is carried on the X chromosome. The other is carried on an autosomal gene, which means the first successful gene therapy was actually a clinical trial for the disease ADA, SCID, started in 1990. There was a child named Ashley De Silva who was treated and exhibited a temporary response to his disease. In 2002, 12 years after that clinical trial began, a number of the patients in the trial, and there were only a handful to begin with, developed a leukemia, and the trial was discontinued while the treatment was being improved. In 1993, Andrew Gobia was born with SCID following a prenatal genetic screening. So they knew before this other child was born in 1993 that he was going to have the disease. So what they did was they saved cells from his mother's placenta and from the umbilical cord that contained her working copy of the ADA gene that is responsible for SCID, and they just injected those cells into his blood. For 4 years, his T cells produced the ADA enzymes that were required to stop this from becoming a disease. In 2002, a number of patients from the original Ashley De Silva trial developed leukemia, and this caused a great stir, as it should have. Since that failure in 2002, researchers have begun new trials in the United States, in the UK, in France, Italy, and Germany, using safer viral vectors that are much less likely to cause cancer. And later on, we're going to talk about what these specific vectors are and what the technologies are and how they compare with one another. And there really are only a handful of techniques that are used, and so it's not so difficult to talk about how they work. GlaxoSmithKline has a drug called GSK 2696273, which is a gene therapy. It uses a viral vector to insert working copies of the ADA gene into bone marrow stem cells. The Europeans will be reviewing an application built on data from 18 patients, with the first treatment dating back 13 years. All of the patients are alive, though 3 of them have had follow-up enzyme replacement therapy or bone marrow transplant. So that's important and encouraging. And so for some period of time, as much as 13 years, the patients are alive. 3 of them are not making enough ADA protein by themselves, but presumably that means that the other 15 are. So that's quite encouraging. The next disease, which is an immune deficiency disease that I want to talk about, is chronic granulomatous disease, or CGD. Is a rare and diverse group of hereditary diseases in which certain cells of the immune system have difficulty forming the reactive oxygen compounds used to kill certain ingested pathogen. This leads to the formation of granulomata in many organs. Most cases of CGD are caused by an X-linked mutation of the GP91 gene. So the disease really refers to the phenotype or the characteristics of the disease rather than the genotype. One particular form of CGD is caused by one mutation on the X chromosome on a gene called GP91. And so they will not have the disease any longer. In 2006, 2 patients with this X-linked CGD underwent gene therapy and blood cell precursor stem cell transplantation to their bone marrow. Both patients recovered from their CGD, clearing pre-existing infections and demonstrating increased oxidase activities in their neutrophils. All good news. In 2012, a 16-year-old boy with CGD was treated with an experimental gene therapy which temporarily reversed the CGD and allowed him to overcome a particular life-threatening lung disease. Okay, the next autoimmune disease that I want to talk about that has had some success with gene therapy is AIDS. In the 1990s, there was a student from the United States who's come out and talked about this and is a political activist who I really admire. His name is Timothy Brown, and he became infected with the virus when he was studying in Berlin, Germany. He developed, in addition to the HIV infection, which was being treated with standard antiviral medication, he developed leukemia. So it was kind of a double whammy for him. And after a while, they decided to give him a bone marrow transplant, which is not an unusual treatment for leukemia. But these particular doctors were really smart, and they knew something that had been observed fairly recently about certain people, about 10% of people of European descent, have a deletion in a gene called CCR5. Those people essentially cannot become infected with the most common variety of HIV. And the reason for that is that this particular gene codes for a protein which is presented on the outside of T cells. And that is the thing that HIV needs to grab onto in order to recognize the T cell, which is the main thing that HIV. So what these clever doctors did is they said, well, we're going to be giving Mr. Brown a bone marrow transfusion. So why don't we go ahead and find a donor that doesn't just match his blood type and his tissue type, but who also has this CCR5 mutation, so that the new bone marrow that we give to Mr. Brown will contain cells that cannot produce the protein that HIV recognizes. So they did that. After a few rounds of treatment, he went into remission from his leukemia. his T cell levels rose from the T cells that were being produced from the stem cells that came from the donor that had the CCR5 mutation, and he has remained free of HIV infection without the need for antiretroviral drugs. This seems like a good thing to do for people whether they have leukemia or not. Wouldn't this be a good way to cure people who have HIV? So I'm not sure specifically why we wouldn't want to do this. Why not take people who have HIV and give them bone marrow stem cell transplants with donors who have this particular mutation? It seems to work quite well. And this is just conjecture on my part, but presumably there aren't very many of these kind of donors. And there are a lot of people who have HIV, and so it might be difficult to find enough of those donors. That might be one problem. Another problem is that when you deal with this kind of personalized medicine, it is very expensive. It's painful. It has a certain amount of risk, especially for somebody who is immune compromised in the first place, to completely shut off their immune system, obviously. So, there are a lot of reasons why one might not do it. Maybe it would make more sense to figure out a way to get this mutation of the CCR5 gene into patients' own stem cells without needing to find a donor and without needing to completely turn off their own immune system. So is that possible? Well, there are some tests that are going on. The first one involves a drug called SB728. This gene editing technique is being evaluated in clinical trials, and it uses a programmable nuclease zinc finger to disrupt the CCR5 gene. So in this case, we have people who produce normal CCR5, which means that, like most of us who produce normal CCR5, HIV can recognize our T cells. So we would like to turn off the ability of that protein to be made and expressed on the surface of T cells. So right off the bat, this is a harder thing to do than anything that we've talked about so far. It's one thing to introduce some working amount of a protein that otherwise wasn't being made, but it's something else entirely to be able to turn off something that is normally being expressed. So that's obviously much harder. We have to be able to turn off a significant amount of this naturally occurring protein and for a significant period of time. Between 2011 and 2013, researchers used SB728 to modify the genomes of helper T cells obtained from 12 volunteers who were HIV positive. All the patients experienced a boost in their T cell count. Each patient established a small but stable subpopulation of immune cells with edited CCR5 genes. Okay, so what that means is that their own immune system was continuing to express CCR5 mostly, that HIV could recognize those T cells, but there were enough T cells being produced without the CCR5 protein that the HIV could not identify and target, so that those T cells could provide the patient with some significant amount of immune response, which caused their T cells overall to increase. So that's promising. In a separate study, 3 patients, in addition to editing helper T cells, The researchers also used SB728 to modify killer T cells, which can be used which can also be destroyed by HIV infection. 2 of 3 patients experienced a profound drop in viral load, and they have not had to take antiviral treatment for more than a year. The next drug that I want to talk about is called VRX496. It is a gene-based immunotherapy that uses a lentiviral vector to deliver antisense CCR5, and it was tested in a phase 1 clinical trial. The drug was well tolerated, and all patients had a stable or decreased viral load. 80% had stable or increased T cell counts, and all had stable or increased immune response. This was the first evaluation of a lentiviral administered in a U.S. clinical trial. 12 HIV patients had been treated since 2009. Another programmable nuclease called CRISPR-Cas9 can mutate long-term repeat sequences of HIV-1 in vitro, resulting in removal of the integrated proviral DNA from part of the host cell and a significant drop in viral expression. So this is another technology that's being tested for use in HIV, where you actually remove the viral DNA that has been incorporated into the patient. So one of the things that retroviruses like HIV do is that they inject their genetic material directly into our chromosomes, making it part of our cells in perpetuity. So this CRISPR-9 system can actually edit out or cut out specific pieces of our genetic code permanently. And we'll get into some of the ethical as well as safety issues. So the next disease is Wiskott-Aldrich syndrome. It is an X-linked disease that leaves children open to infection, autoimmune diseases, and cancer. In 2009, promising results were reported for treatment with partially deactivated lentivirus to replace a faulty gene. So here again, this is loss of function, easy pie. All we need to do is put in the working gene so that we can make the correct protein. It's one gene, a monogenetic. So researchers reported promising preliminary outcomes for the first 4 children enrolled in a U.S. gene therapy trial for Wiskott-Aldrich syndrome at ASH last week. All 4 boys were alive and have improved between 9 and 24 months following treatment. Since undergoing treatment, none of the boys have experienced bleeding events or infections, so for 2 years. In addition, all 4 have experienced improvements in immunological systems and variable improvements in platelet counts. The 2 patients who had required medication to stimulate platelet production prior to undergoing gene therapy no longer need those medications. The vector is a self-inactivating lentivirus that has been engineered to avoid triggering the development of leukemia. Okay, so for now I'm going to stop there. The next time I'm going to be talking about heart disease and gene therapy. Thank you for listening. I look forward to the next edition of this lecture series on cancer gene therapy.